Emergency Management of Incarcerated Umbilical Hernia, a short tutorial for Discover Pediatric Surgery by Nirav Patel, Ellen Mapunda, and Hansraj Mangre. Umbilical hernias are the most common congenital abdominal wall disorder and are found in up to 25% of children at birth. The main risk factors for umbilical hernia are Black African race, prematurity, low birth weight, syndromic genetic disorders like trisomy 21, and hypothyroidism. Essentially, an umbilical hernia is a covered fascial defect at the level of the belly button. The diagnosis is clinical and it should not be confused with an epigastric hernia, omphalocele, or hernia of the cord. Management of umbilical hernias is dependent upon a patient's age and symptomatology. Accordingly, any patient under the age of 5 or who is asymptomatic is a candidate for watchful waiting, as these hernias are likely to close spontaneously as children grow. In those children in whom the hernia does not close spontaneously, bowel may pass in and out over time, causing the hernia sac to increase in size. When managing patients with umbilical hernia expectantly, always remember to counsel parents on the danger signs and symptoms of incarceration, including vomiting, a painful red or hard hernia, or a distended tummy. Should parents notice any of these signs or symptoms, they should take their child to the nearest health facility immediately. All children over the age of 5 or those with symptomatic umbilical hernias should be managed surgically. Symptomatic umbilical hernias include those with a previous history of incarceration, with pain attributable to the hernia, or a proboscoid or trunk-shaped hernia that can lead to being teased. In an incarcerated umbilical hernia, the intestine or omentum has become stuck within the hernia sac. The stuck or incarcerated intestine results in intestinal obstruction and pain and is a common surgical emergency in children. Patients can present with a history of swelling at the belly button that now fails to disappear. The onset of the swelling can be associated with pain, irritability, vomiting, constipation, and abdominal distension. In severe cases, you may notice bilious vomitus, edema, and redness of the skin around the belly button, and even blood in the stool. These are all signs of advanced disease. Patients with clinically incarcerated umbilical hernia do not require further imaging and should not be sent unaccompanied for X-ray or ultrasound, as they can easily decompensate. Children with incarcerated umbilical hernia require referral to a specialist center. That said, all these children also require urgent resuscitation whilst awaiting transfer. Start by establishing intravenous access and giving resuscitation and maintenance fluids. Keep the patient warm and give intravenous or per-rectal analgesia. Keep the patient no pause and place a nasogastric tube. Nasogastric decompression is essential as it allows for respiratory and pain relief. If required, provide supplemental oxygen. Remember to always counsel the parents of your suspected diagnosis, what you are doing to address the problem, the need for referral, and the need for surgery. A strangulated hernia is a hernia in which the stuck intestine has become necrotic and is evidenced by bloody stool, edema, and redness of the skin around the hernia. You should never try and reduce a strangulated hernia. If these signs are absent, reduction can be attempted by giving the child analgesia but never sedation, and then applying gentle downward pressure on the hernia sac whilst stabilizing the hernia ring. Remember to always be aware of the possibility of an incarcerated umbilical hernia. Resuscitate patients appropriately. Never leave these patients unaccompanied. Do not send them for unnecessary investigations, and refer early to avoid disastrous and unnecessary complications. Thanks for listening, and please visit the Surgeons for Lives website or the Discover Pediatric Surgery YouTube channel to download and share this and similar tutorials for free.